Hi friends, welcome back to the Nurse channel. So we are very happy to see the responses that you have shown to our previous videos. So as you all aware, we have started a new series, that is the AIIMS NORCET and the ESIC series, and here comes another set of questions which help you to prepare well for the upcoming AIIMS NORCET, ESIC, NAVODAYA and other competitive examinations. And in the previous videos, we have asked you regarding any doubts or any particular topic that need to be discussed. So some of our subscribers, they have asked to explain regarding the renin-angiotensin-aldosterone system and its mechanism. So in this video, I am explaining in brief, in detail about the RAAS system and the questions which can be asked in that area. So I request everyone who are watching this video to watch the video till the end, because the explanations what I am going to give in each questions are also very, very important. And along with that, I will be explaining regarding the RAAS section, RAAS mechanism also. Straight away, without losing time, we will move on to the questions. Before that, kindly subscribe our channel and support us, and enable the bell icon so that you will be notified whenever we are uploading new videos. So straight away, we'll move on to the questions. So here comes the questions for you.
So let us start this session with a very important question from the oncology. Very important question. So the first question for you in the screen right now. So the question is, which of the following is the most common type of oral cancer? So which is the most common type of oral cancer? So the options are: option number A, basal cell carcinoma; option number B, squamous cell carcinoma; option number C, adenocarcinoma; and option number D, mucoepidermoid carcinoma. So there are some more the other peculiarities for all the options what I have given here, like basal cell, squamous cell, adenocarcinoma, and mucoepidermoid carcinoma. So I'll be explaining that in the explanatory session. Before that, we will see the answer for this question. So the most common type of oral cancer is the squamous cell carcinoma. Squamous cell carcinoma. So squamous cell carcinoma is the most common type of mouth cancer, which accounts for 9 out of 10 cases. Okay, squamous cells are found in many places around the body, including the inside of the mouth and under the skin. Okay, so the other carcinomas like a BCC, that is the basal cell carcinoma. So basal cell carcinoma most often occurs on the sun exposed skin. So this can be another question which can be asked, that the cancer which can occur in the sun exposed skin, that is the basal cell carcinoma. So about 85% of the basal cell carcinomas develop on the head and neck area, because these are the most sun exposed areas. So there are very few cases of true intraoral diseases. Okay, intraoral basal cell carcinomas are very, very rare, because that is not a sun exposed area. Okay, so whenever we are talking about basal cell carcinoma, think about the sun exposed skin areas. Okay, then the next option, that is adenocarcinoma. So adenocarcinomas, these are type of cancer that starts in the glandular tissue. Okay, so this is another important point, glandular tissue. So most salivary gland cancers start in the parotid glands. Okay, so another important point, the salivary gland cancers are starting in which gland? That is the parotid gland. And around 80 in 100 salivary gland cancers starts here. Okay, so that is the adenocarcinoma, glandular tissue. In that, the parotid gland is the main thing. Okay, so again another important points for you. And the final option is the mucoepidermoid carcinoma. So it is the most common malignant salivary gland tumor. Okay, so another answer for a question, most common malignant salivary gland tumor, that is the mucoepidermoid carcinoma, which accounts for 10 to 15% of all salivary gland tumors and 1/3 of all salivary gland malignancies. Okay, so from the first question itself, from each options, from the 4 options, you are getting nearly 8 to 10 points that can be asked for the competitive examinations. Okay, so we'll move on to the second question in our series. So the question is, which of the following symptoms is not a characteristic manifestation of anorexia nervosa? Okay, so here the question is, which is not a characteristic feature of anorexia nervosa? So to answer this question, you should know what is anorexia nervosa and what are the features that can be seen in patients. So before that, we will see the options for this question. The first option is option number A, menorrhagia; option B, pallor; option C, hypotension; and option D, amenorrhea. So which is not a characteristic manifestation of anorexia nervosa? So I'll explain in detail in the explanatory session. Before that, the answer for this question is obviously option number A, menorrhagia. Menorrhagia is not a characteristic of anorexia nervosa. So first of all, we will see anorexia. It is an eating disorder which is characterized by an abnormally low body weight, an intense fear of gaining weight, and a distorted perception of weight. Okay, it's an eating disorder which is characterized by low body weight, intense fear of gaining weight, and distorted perception of weight. So of women presenting with the anorexia like illness, between 68 and 89% report absence of menstruation for at least 3 months during the course of their illness. So there will be amenorrhea will be there at least 3 months during the course of their illness. An additional 6 to 8% of the women may experience prolonged amenorrhea but report menstrual irregularity or oligomenorrhea. Okay, so the two things that you have to remember regarding the menstruation issues that can happen in anorexia nervosa is the amenorrhea and oligomenorrhea. Okay, so severely restricting the amount of calories stops the production of the hormones which are needed for the ovulations. That's why in anorexia nervosa cases, these periods are not getting regular. Okay, there will be absence of menstruation and sometimes oligomenorrhea also will be there. There will not be menorrhagia. Okay, these are the 2 points that you should remember. And other features include dry skin, pallor, bradycardia, hypotension, intolerance to cold, and constipation. These are the other manifestations which can be seen in patients with anorexia nervosa. Okay, so this is in short regarding the manifestations of anorexia nervosa and especially the menstrual features. Okay, so we can see the third question in this series. So your task is to identify the treatment option for spontaneous pneumothorax. So regarding pneumothorax and other related aspects, we have already covered in the previous videos. Many questions I have included from pneumothorax so that you can go through if you have not seen yet. So this here the question is asking regarding the treatment option for spontaneous pneumothorax. And the options are option number A, corticosteroids, B, thoracocentesis, C, mechanical ventilation, and D, ICD, that is intercostal drainage. So which is the treatment option for spontaneous pneumothorax? So definitely answer is option number D, that is intercostal drainage. Have you heard about a triangle named safe triangle? So that I will be explaining now. So a chest tube or the intercostal drain is the most definitive initial treatment of a pneumothorax. So the chest tube is typically inserted in an area under the axilla or the armpit, which is called as the safe triangle. You can see the picture here where the damage to the internal organs can be prevented or avoided. So chest tube permits the continuous escape of air, thus helping the lung to re-expand by establishing a negative pressure in the pleural space. So this is the principle behind the chest tube insertion. There will be lung expansion, re-expansion is happening with establishing a negative pressure by in the pleural space by inserting the intercostal drainage. So you can see the safe triangle here below the axilla. Sorry, in the axilla, that triangle which is formed by the in the fifth intercostal space, and the lateral edges are by the lateral edge of pectoralis major muscle, and the other area of the triangle is formed by the lateral edge of latissimus dorsi. Okay, and this is the base of the axilla. So in this area is the safe area for inserting the ICD. So this is another point you have to remember regarding the ICD. Okay, so we will see the other options what I have given in the question. So what is a thoracentesis? Thoracentesis and ICD insertion, that is different. So thoracentesis, also known as the thoracocentesis or the pleural tap or the needle thoracostomy or needle decompression. Okay, all these terms are very important. Question can be asked from any of these areas. Like the thoracentesis, also known as thoracocentesis or pleural tap or needle thoracostomy or needle decompression. So it is an invasive medical procedure to remove the fluid or air from the pleural space for the diagnostic or therapeutic purposes. Then thoracocentesis is done as a life-saving measure in tension pneumothorax. Okay, in tension pneumothorax when delay is anticipated in inserting a chest tube. So if a chest tube insertion is delayed, then the thoracocentesis is the indication. Okay, is a life-saving measure. And mechanical ventilation is indicated in patients with more severe disorder. Example, hemopneumothorax accompanied by flared chest. Okay, so in our question it was related to the spontaneous pneumothorax, but mechanical ventilation is not indicated unless and until the case is more severe. Example, in hemopneumothorax, that is a blood and air, okay, accompanied by the flared chest. Okay, so that's why mechanical ventilation is not an answer for the question what I have asked. Okay, so what is ICD, where the ICD can be inserted, what is safe triangle, what is thoracentesis, and when mechanical ventilation is indicated in pneumothorax. These things I think you have got the point out of this question. Now we can see the fourth question in our series. So the question is, which among the following defines wedge resection of lung? Okay, so this is the surgical management for the lung cancers. So there are so many terms that you have to remember as far as this lung surgeries are concerned. So here the question is regarding the wedge resection, and the other terms I will explain in the explanatory session. So first of all, we will see the options for this question. Options are option number A, one entire lung. Option B, a lobe of the lung. Option C, small localized area of lung. And option number D, one segment of the lung including a bronchiole and its alveoli. So what do you mean by wedge resection? So that's the question, wedge resection. Is it only one entire lung, a lobe of the lung, a small localized area of the lung, or a segment of the lung including the bronchiole and its alveoli? So there are terms for each and every options what I have given here. So that I will be explaining soon. Before that, the answer for the question wedge resection is the small localized area of the lung is getting removed. Okay. So we will see each one. So the first one is a lobectomy. So what do you mean by a lobectomy? So lobectomy, it is the surgical removal of one of the 5 lung lobes. Okay. So one of the 5 lung lobes, if it is surgically removed, it is known as the lobectomy, like right upper, right middle, right lower, left upper and left lower lobes. So lobectomies are the most common type of lung surgery. So another important point, which is the most common type of lung surgery, that is a lobectomy, that removal of one of the 5 lung lobes. Then next term that you have to remember is a sleeve lobectomy. So what do you mean by a sleeve lobectomy? So it is a lobectomy that is coupled with the removal of a part of the main bronchus. So along with a lobe, the part of a main bronchus also will be removed. Then that procedure is known as the sleeve lobectomy. Okay, so I think you understood the difference between lobectomy and sleeve lobectomy. Then comes the segmentectomy. So what do you mean by segmentectomy? So as the name indicates, it is a surgical removal of bronchopulmonary segment, and it often involves the removal of 2 adjacent segments. Okay, so there will be surgical removal of the bronchopulmonary segment, that is segmentectomy. Then the next point that you have to remember is the answer for the question I have asked, that is a wedge resection. So what do you mean by wedge resection? So it is a non-anatomical removal of a triangular shaped piece of tissue from the lungs. Okay, so it is a non-anatomical removal of a triangular shaped tissue. So it involves the removal of a small localized area containing the tumor near the surface of the lung, that is known as the wedge resection. Okay, so I think among these terms, don't get confused. These are very important. Then one more term you have to remember in exam point of view, that is the bleb resection. So what do you mean by a bleb resection? So it is a surgical removal of one or more blebs. So what is a bleb? It's a small collection of air between the lung and visceral pleura. Okay, so bleb is a small collection of air that can be seen between the lung and visceral pleura. So the surgical removal of that one or more blebs is termed as the bleb resection. Okay, so in this slide you can see what is lobectomy, sleeve lobectomy, segmentectomy, wedge resection and bleb resection. Okay, so these terms please keep in mind, and with that we can move on to the 5th question in our series. The 5th question, which among the following describes the most common pain characteristic in angina? So I'll simplify the question. So I'll be giving the options. In that options, which pain characteristics describe angina? Okay, angina. So the options for you are option A, throbbing pain, option B, heaviness, option C, sharp pain, and option number D, knife-like pain. So these options are the pain characteristics of one or the other disease conditions that I will be explaining soon. So before that, the answer for our question, that the angina characteristic pain is option number B, that is heaviness. Heaviness will be there, heaviness. So what do you mean by throbbing? First of all, we will see the other options. The first one is throbbing. So throbbing results from the dilation of blood vessels from the increased blood flow. Okay, so there will be dilated blood vessels can be seen, and throbbing often feels like a pulsing sensation, and can come and go quickly. Okay, so these are the characteristics of the throbbing pain, and throbbing pain is often associated with toothache, headache, migraine and pain in the extremities, but can occur nearly anywhere in the body. Okay, so throbbing means, just remember this point, that is a pulsing sensation pain. Okay, so that type of pain can be seen in obviously tooth pain, headache, migraine and pain in the extremities. So that is throbbing. Then the another option was And then I'll explain the answer for the question I have asked. That patients with angina usually describe the chest pain as tightness. There will be tightness, then heaviness, then pressing and squeezing or burning type of pain. Okay, so angina pain will be explained by the patient as a there will be chest tightness and heaviness, then pressing and squeezing effect, squeezing or burning pain. So these are the characteristics of the angina pain. So that's the answer for the question. Then I have explained, I asked about the shooting pain, shooting or the knife like. So that I'll be explaining now. So common causes of the shooting nerve pain throughout the body may include the brain, spine, or the nerve injuries, vitamin B12 or the thiamine deficiencies, then poor blood supply to the nerves, heavy drinking, etc. So these are the reasons for shooting nerve pain. And the final option was the knife like and the sharp pain. So this is usually associated with pericarditis and pleuritis. Okay, so this type of pain can be seen in knife like, and sharp pain can be seen in pericarditis and pleuritis. Okay, so for pain characteristics and its disease conditions, you got the point out of this question. Now we can see the sixth question in our series regarding the varicose vein. Select the curative management for varicose vein. So question, read carefully. Here the question is asked about the curative, that is important, curative management for varicose vein. So the options are option number A, PTBA. What is PTBA? That is a percutaneous transluminal balloon angioplasty. Then option number B, sclerotherapy. Option number C, ligation and stripping. And option number D, laser treatment. So which is the curative management for varicose veins? So the answer is option number C, that is a ligation and stripping. Okay, ligation and stripping. So first of all, we will see what is a ligation and stripping. Ligation and stripping of the vein is done as a curative measure, and venous ligation, so as the name indicates, essentially means the tying of the varicose vein through small incisions made in the skin in the affected areas. And what is a stripping? Stripping refers to the removal of the larger varicose vein in a similar manner. Okay, the same way small incisions will be made in over the skin, and the larger varicose veins can be removed. That is stripping. So ligation and stripping stands as the curative measure for the varicose vein. Then what about the other options like sclerotherapy, laser, etc. So sclerotherapy means some medicine called as a sclerosant is injected into the veins to make them shrink. So the sclerosant agent will cause the veins to shrink, and these medicines that are commonly used as the sclerosants are, first one is the polidocanol, then sodium tetradecyl sulfide, then hypertonic saline, glycerin, and chromated glycerin. So why I have tell about this sclerotherapy is this, from this area question can be asked. So the glycerin and chromated glycerin or hypertonic saline can be used as a sclerosant for the sclerotherapy for the treatment of varicose vein. Okay, so that's why I have included this point. Then regarding the that endovenous laser treatment. Okay, endovenous laser treatment, this is also another treatment option for the varicose vein. So endovenous laser treatment of the varicose vein uses the lasers that generate high energy. So what is the mechanism how the varicose vein can be treated? It is not a pakka curative management, but how it can be used for the treatment is the produced heat is absorbed by the hemoglobin and the surrounding tissue, which then results in the formation of steam bubbles. Okay, so the hemoglobin will get absorbed by the heat which is produced, which can result in the formation of steam bubbles, and these bubbles cause the blood to boil and induce thermal injuries to the venous endothelium and intima, and thereby reducing the diameter of the vessels. Okay, this can induce the thermal injury to the venous endothelium and the intima. Okay, so that is a EVLT, that is the endovenous laser treatment. Okay, so that also was very informative. Now we will move on to the seventh question in our series. So the drug of choice in acute attacks of asthma is dash. So drug of choice in acute attacks of asthma. So the options are option number A, oral steroids, option number B, morphine and propranolol, option number C, salbutamol inhalation, and option number D, aspirin. So which is the drug of choice in attacks of asthma? So the answer is obviously option number C, that is salbutamol inhalation. So if you got an option like that inhaled steroids, then that also can be an answer. But here the option I have given is oral steroids, so it won't come as the answer. So salbutamol inhalation stands as a drug of choice in acute attacks of asthma. So what is the aim? Aim is like bronchodilation need to be happened. So bronchodilation can be achieved by administering salbutamol, which is a beta 2 agonist by nebulization or by metered dose inhalation. Okay, so the inhaled salbutamol produces bronchodilation within 5 minutes, and it is the drug of choice in the acute attacks of asthma. So beta 2 agonist, salbutamol is a beta 2 agonist. That is also important. Then the other options we will see why and those options are contraindicated in bronchial asthma attacks. Why? That we will see. First of all, the beta blockers. I have given that propranolol and morphine as another option. So beta blocker belongs to the propranolol, which belongs to the beta blocker category, are key in the management of managing cardiovascular diseases. But blocking the airway beta 2 receptors can cause severe and sometimes fatal bronchoconstriction in people with asthma. So there will be worsening of the symptoms can happen with administering of beta 2 receptors blockers, okay, beta blockers. Then what about morphine? So morphine, you know that it is a central nervous system depressant, and it can also precipitate further asthmatic attack by its histamine releasing action. Okay, so morphine itself can cause a respiratory depression, and at the same time, because of its histamine releasing action, the morphine can worsen the symptoms in bronchial asthmatic attacks. So morphine also is not advisable in bronchial asthma attacks. Okay, then the other option, up to 20% of the asthmatic population is sensitive to aspirin. So in the one option was aspirin. So many asthmatic patients are sensitive to aspirin and other non-steroidal anti-inflammatory drugs, that is NSAIDs, and present with a triad of rhinitis, sinusitis and asthma when exposed to the offending drugs. Okay, so this can worsen the symptoms. This syndrome is referred to as the aspirin-induced asthma, okay, AIA. So aspirin-induced asthma named a syndrome also is there. So in that case, aspirin also is not advisable for acute bronchial attacks. Okay, so I think that also was very informative, important question. Now we will see the eighth question in the series. So which among the following is not present in the classical triad of a ruptured AAA? So what is AAA? Abdominal aortic aneurysm. Okay, so here the question is regarding the ruptured aortic aneurysm, and what is a classical triad and which one is not included in the classical triad of a ruptured AAA. So the options are option A, dyspnea and palpitation, option B, sudden severe back pain, option C, pulsatile mass in the periumbilical area, and option D, hypotension and bradycardia. So which is not included in the triad of symptoms in ruptured AAA. So the option number A is the answer for this question I have asked. So we know that it is reported that nearly 25 to 50% of the patients with the ruptured abdominal aortic aneurysm present with a classical triad of hypotension, flank or the back pain and pulsatile mass in the periumbilical area. So this is a classical triad of patients presenting with ruptured abdominal aortic aneurysm. So the possible presentations of the rupture can include hypotension of unknown etiology, then groin or the back pain and sometimes the lower extremity pain. And if the abdominal aortic aneurysm ruptures posteriorly into the retroperitoneal space, then bleeding may be tamponated by surrounding structures, preventing exsanguination and death. Okay, and in this case the patient will have sudden severe back pain, and patient may also have back or the flank ecchymosis. So this is in case if it is happened in the posterior space, and if the rupture occurs anteriorly, then the patient will have severe bleeding leading to hypovolemic shock. That is, patient can go into the stroke. But any cause, if it is not treated or if it is not identified at the right time, there will be chances for fatality, that is death can happen. Okay, so that is a ruptured abdominal aortic aneurysm and its classical triad. So moving on to the 9th question in our series. So the most common cause of conductive hearing loss. So which is the most common cause of conductive hearing loss? Options are option number A, foreign body, option number B, otitis media, option C, ototoxic drugs, and option number D, allergy. So which is the most common? Question is most common cause of conductive hearing loss. So the answer is option number B, that is otitis media. Otitis media with exudate. Okay. So we will see regarding this conductive hearing loss. What do you mean by conductive hearing loss? So it occurs when there is a problem transferring the sound waves anywhere along the pathway through the outer ear, tympanic membrane or ossicles. Okay. So if there is any problems transferring the sound waves anywhere along the pathway, which include the outer ear, the tympanic membrane or the ossicles. So the pathologies in the middle ear resulting in the conductive hearing loss include acute otitis media and otitis media with effusion, which is commonly referred to as blue ear. So otitis media is the main reason and that with effusion means that will add on the problems. Okay. So otitis media with effusion is the most common cause of acquired hearing loss in children. Okay. So the other options like noise pollution, ototoxic drugs, these are the causes for the sensory neural hearing loss. So what is a sensory neural hearing loss, that you can refer later. So these are some of the causes for the ototoxic drugs, and noise pollution are examples for the causes for sensory neural hearing loss. Okay. So moving on to the 10th question in our series. So a simple question, which part of the brain is evaluated by mental status examination? So we know that for psychiatric patients, mental status examination will be done. So by doing this, which lobe of the brain is getting evaluated? So options are option A, cerebrum, option B, midbrain, option C, cerebellum, and option D, thalamus. So which area of the brain is evaluated by doing mental status examination? So obviously answer is option number A, that is cerebrum. Cerebrum is the answer. So mental status examination includes, that mental status includes level of consciousness, then orientation, memory, mood, intellectual functioning, judgment and insight, language and communication. So these are the parameters that we are looking in the mental status examination. So by performing a thorough examination of the mental status, different areas of the cerebral cortex are evaluated. Okay, the cerebral cortex is getting evaluated by doing the mental status examination, which include many parameters like level of consciousness, orientation, mood, memory, intellectual functioning, insight, judgment, language, communication, etc. Okay, so that was a simple question. Moving on to the 11th question in our series. So the most common early manifestation of chronic bronchitis. Okay, so again question, read carefully. Most common early manifestation, not the late manifestation. Most common early manifestation of chronic bronchitis. Options are option A, daily productive cough, option B, dyspnea, option C, cyanosis, option D, right ventricular failure. Most common early manifestation. So the answer is option number A, that is daily productive cough. Daily productive cough. So you know that the most common early manifestation of chronic bronchitis is a daily productive cough which lasts for 3 months in each of 2 successive years in a patient in whom other causes of the chronic cough have been excluded. Okay, so this is a criteria to diagnose a chronic bronchitis. So there should be daily productive cough which lasts for 3 months in each of the 2 successive years. We have to exclude the other causes for cough. Okay, so patient with chronic bronchitis progress to develop dyspnea. So later it can be progressed to dyspnea, then cyanosis and right ventricular failure in the later course of the disease. Okay, so right ventricular failure also can happen during the late course of the disease. Okay, so the question, sudden muscle contraction of varying intensity involving a part or the entire body is termed as. So the question is regarding a type of muscle contraction in which it will be varying in intensity and it can involve a part or the entire body. So what is the term is called? So option A, chorea, option B, myoclonus, option C, tic, and option D, tremors. So all the options what I have given is one or the other type of kinetic disorders or symptoms. So find out the question what I have asked. Sudden muscle contraction of varying intensity involving a part or the entire body. So that is option number B, that is myoclonus. So I'll be explaining all these 4 options and what all are the differences between these 4, among these 4, that I'll be explaining soon. So first of all, we will see what is a myoclonus. So myoclonus, it is a brief involuntary. So this is involuntary, irregular. That means there will not be any rhythm, twitching of a muscle or a joint or a group of muscles, which is different from clonus. Clonus means which is rhythmic and regular. So myoclonus means it is irregular, but clonus means that will be regular. Okay, and there will be twitching of a muscle, a joint, or a group of muscles. Okay, so that is myoclonus. So these myoclonic twitches or jerks or seizures are usually caused by sudden muscle contractions. That means that is a positive myoclonus, or brief lapses of contraction, that is known as the negative myoclonus. Okay, so myoclonus itself is two terms you have to remember, that is positive myoclonus, which are caused by the sudden muscle contractions, or if it is causing because of a brief lapses of contraction, that it is termed as the negative myoclonus. Okay, so you are getting terms like myoclonus, positive myoclonus, and negative myoclonus. Then we will see the other options. So what is a chorea? So what is chorea? Chorea is characterized by brief, semi-directed, irregular movements. Okay, brief, semi-directed, irregular movements that are not repetitive or rhythmic, but appear to flow from one muscle to the next. Okay, so these dance-like movements of chorea often occur with athetosis, which adds twisting and writhing movements. Okay, that twisting and writhing movements is otherwise known as the athetosis. Okay, so chorea is characterized by brief but semi-directed irregular movements that are not rhythmic. Okay, and it can flow from one muscle to another. So chorea is discrete, jerky, purposeless movements in the distal extremities and face. Okay, so that is chorea. Then tic. Tic, you know that tic is the involuntary movement of groups of muscles in stereotypic pattern. Okay, that is in a stereotypic pattern. And a tremor is the involuntary trembling or quivering of the muscles. Okay, so this is the difference between tic and tremor. Okay, so you are getting 4 terms out of this. That is a myoclonus, in that we have explained positive and negative myoclonus, then chorea, tic, and tremor. Okay, so with that we are finishing the 12th question in this series. We will move on to the 13th one. So the question is regarding the pressure ulcer. Very important question. So full thickness ulcer extending to the subcutaneous tissue is graded under which stage of pressure ulcer? So stages of pressure ulcer or grades of pressure ulcer is very important in exam point of view. So here the question is full thickness ulcer that is extending to the subcutaneous tissue. You will grade under which stages of pressure ulcer? That is the question, and the options are option number A, stage 1, option B, stage 2, option C, stage 3, and option 4, stage 4. Option D, stage 4. So full thickness extending to subcutaneous tissue. So obviously answer is option number C, that is stage 3. So I will be explaining to you the stages or the grades of pressure ulcer with the help of this diagram that you can see in the screen right now. Very important diagram or the picture that you should remember. So the stages of pressure ulcer can be staged under 4 stages: stage 1, 2, 3 and 4. So the stage 1, in the stage 1 you can see the picture here. With the help of the picture, I can identify stage 1. There will be a redness or non-blanching erythema will be there. Only redness will be present with intact epidermis. There will not be any break in the skin. Okay, the epidermis will be intact. So that is stage 1. So you can see this is the heel of a patient, and you can see there is a redness or non-blanching erythema will be there. Okay, then comes to stage 2. This is the next stage in which there will be partial thickness ulcer. So there will be partial, this is the original picture and this is a schematic diagram. So you can see a partial thickness ulcer. It involves the dermis and the epidermis. So here the epidermis and the dermis is involved. Okay, epidermis and the dermis is involved. Here the partial thickness is happening, including the epidermis and the dermis. Then comes the stage 3. So that was the answer for the question I have asked. You can see the picture here. So you can see the full thickness ulcer will be there. Here it was partial thickness. Here you can see full thickness ulcer that is extending through the dermis into the subcutaneous tissue. So in the schematic diagram you can see that is the epidermis, dermis, and you can see here it has involved the subcutaneous tissue. Okay, the subcutaneous tissue also involved. Such type of pressure ulcers can be graded as the stage 3 pressure ulcer. Okay, stage 3.
and last comes the stage 4 pressure ulcer. Stage 4 pressure ulcer, that will be deep tissue destruction and extending through the fascia and may involve the muscle, bone and the tendons. Okay, so this is the original picture of a stage 4 pressure ulcer. So you can see that the bone and the tendons are also involved. Okay, so here the schematic diagram, the epidermis, dermis and subcutaneous tissue, then the muscles and the fascia, everything is covered and it has extended up to the bones and the tendons. Okay, so that is a stage 4. So definitely this is an important, very important area that you have to study in exam point of view. So you can expect questions out of this for your ESIC and the NORCET examination. Okay, so that's all regarding the stages of pressure ulcer. Now we will see the 14th very another important question in this series. So select the correct sequence in how the RAAS works. So you have to select the correct sequence in how the RAAS, that is the renin angiotensin aldosterone system, works. Okay, so option A, angiotensin 1, angiotensin 2, ACE, renin angiotensinogen. Option B, renin angiotensinogen, angiotensin 1, ACE angiotensin 2. Option C, renin angiotensin 1, angiotensinogen, ACE angiotensin 2. And option D, angiotensinogen, renin, ACE, angiotensin 1 to angiotensin 2. So what is the correct sequence in which the RAAS works? So what is the answer? So in the introduction section, I have told that I will be explaining regarding the RAAS system today. So first of all, we will see the answer for this question and I will be giving you a detailed explanation exam point of view regarding the RAAS system. So the answer for the question what I have asked is the renin angiotensin. Renin angiotensinogen is converted to angiotensin 1, then ACE. With the help of ACE, it will convert it to angiotensin 2. Okay, so this is the correct sequence what I have given, correct sequence among the options what I have given. So I'll be explaining regarding the RAAS system with the help of this diagram. So you can go through this diagram and I'll be explaining the things in exam point of view. Okay. So the renin angiotensin aldosterone system. So this can be called as renin angiotensin system also. Okay, symbol RAAS also it can be called. Okay, so what is RAAS? So this renin angiotensin aldosterone system, it is a hormone system. Okay, that means many hormones are involved in this process, and this hormone system regulates 3 factors. Okay, this renin angiotensin aldosterone system regulates mainly 3 factors. The first one is the regulation of BP. First one is the regulation of blood pressure. Then second one is the regulation of the fluid and electrolyte balance. Okay, fluid and electrolyte balance will be regulated, and the final one is the management of systemic vascular resistance. Okay, so these 3 things are getting managed by the renin angiotensin aldosterone system, and it is very important in the homeostasis. Okay, so it is a hormone system that regulates 3 factors. First one is the blood pressure, the second one is the fluid and electrolyte balance, and third one is the systemic vascular resistance. So now I will be explaining the physiology of the renin angiotensin aldosterone system, and I will be explaining only simple points that will be asked for the examination. Exam point of view, what all things you need to learn, that will be explaining shortly in this session. Okay, so the first of all, what will happen is whenever there is a hypovolemia or there is a reduced blood flow or perfusion to the kidneys, the juxtaglomerular cells, you can see JGA, that is a juxtaglomerular apparatus. So the juxtaglomerular cells in the kidneys, it will convert the precursor prorenin into renin. Okay, so in the circulation you have prorenin. So the prorenin will be converted to renin by whom? By juxtaglomerular apparatus in the kidney when there is a reduced blood flow or when there is a reduced perfusion. So the renin which is in the circulation now will convert the angiotensinogen which is released by the liver. Okay, so this is another important point that you have to remember. Angiotensinogen will be released by which organ? That is by the liver. Okay, so the angiotensinogen which is released by the liver will be converted to angiotensin 1 by this renin. Okay, so the renin, it will be there in the circulation prorenin will be there in the circulation, and the prorenin is converted to renin by the juxtaglomerular apparatus of the kidney, and this renin will convert the angiotensinogen to angiotensin 1. Okay, so this is the first step that you have to remember. Now we have this angiotensin 1 in the circulation. Okay, understood now? Angiotensin 1 in the circulation. So now this angiotensin 1 is subsequently converted into angiotensin 2. Okay, by whom? This is converted by the angiotensin converting enzyme, otherwise known as the ACE. Okay, angiotensin converting enzyme. And from where this angiotensin converting enzyme is coming? So that is also another important question which can be asked. This ACE is found on the surface of vascular endothelial cells, predominantly those of the lungs. Okay, so predominantly the ACE will be secreted by the lungs. Okay, so about this one question I have included in the last session. So ACE will be secreted by the vascular endothelial cells, predominantly from the lungs. Okay, so now with the help of the ACE, this angiotensin 1 is converted into angiotensin 2. So this is the second step that you have to remember. So first one, angiotensinogen to angiotensin 1 by the renin, and the second one, angiotensin 1 to angiotensin 2 by the ACE inhibitor. Okay, so now the angiotensin 2 is the key factor in maintaining all the things what I have explained in the introduction. That means the regulation of the blood pressure, regulation of the fluid and electrolyte imbalances, and then the systemic vascular resistance. Okay, so that I will be explaining now. So some more points I can add to you, that the angiotensin 2 can also be converted into angiotensin 3, angiotensin 4 and all, but in our exam point of view that is not much important. So now the angiotensin 2. So angiotensin 2, it is a potent vasoconstrictive peptide. Okay, angiotensin 2 is a potent vasoconstrictive. So you can see here vasoconstriction, vasoconstrictive peptide that causes the blood vessels to narrow, resulting in the increased blood pressure. So from this action itself, there will be increase in the blood pressure. That is the first thing. Okay, understood now? Then angiotensin 2 also stimulates the secretion of hormone aldosterone from the adrenal medulla, adrenal cortex. Okay, so this is the adrenal cortex. So from the adrenal cortex, what will be released? That the aldosterone will be released. Okay, aldosterone will be released, and aldosterone in turn, what will happen? This aldosterone causes the renal tubules to increase the reabsorption of sodium. Okay, so you have to remember, from the aldosterone, because of the release of the aldosterone, it causes the renal tubules to increase the reabsorption of sodium, which in consequences causes the reabsorption of water into the blood. Okay, so there will be reabsorption of water also, and at the same time causing the excretion of potassium. Okay, so why? So this aldosterone, because of the aldosterone, what will happen is sodium and water retention will be there, and at the same time potassium excretion will be there. So this is for the electrolyte balance. So the second factor, so first of all we have told that the systemic vascular resistance will be increased by constricting the veins, so constricting the vessels, causing the increase in the BP. The second one is the increase in the retention of water and sodium. At the same time there will be excretion of potassium, and thereby maintaining what will be maintained? There will be maintaining the electrolyte balance, and as a result of the sodium and water retention, there will be increased fluid circulation. There will be increase in the amount of fluid, and thereby that also will increases the BP. Okay, that also will increases the BP. So that is the aldosterone, role of aldosterone. Okay, so now next comes the posterior pituitary. So this will, angiotensin 2 will stimulate the posterior pituitary to release what? That is the anti-diuretic hormone. Okay, so posterior pituitary, from the posterior pituitary anti-diuretic hormone will be released, and it will, this anti-diuretic hormone will stimulate the collecting duct in the nephron, and it will cause water reabsorption. Okay, so water reabsorption will be happened, and antidiuresis, okay, anti-diuretic hormone, antidiuresis will happen, and as a result of this there will be fluid buildup in the body and can cause
the increase in the BP. So this is the another mechanism by the ADH, anti-diuretic hormone, from the posterior pituitary. Okay, understood. So all together, so we have explained what all things we have explained in this session. We have explained because of the potent vasoconstrictive effect of the angiotensin 2, what will happen is that there will be vasoconstriction, systemic vascular resistance happens, and directly that will increase the BP of the patient. Then it will stimulate the aldosterone, and the aldosterone itself will cause what? There will be sodium and water retention, and at the same time potassium will be excreted, that maintains the electrolyte balance of the body, and at the same time there will be water content of the body will be increased, will cause the increase in the BP. And sodium and water reabsorption already we have explained. And the posterior pituitary, that the ADH, antidiuretic hormone, will be released, and it will stimulate the collecting ducts of the kidneys and can cause the water reabsorption from the collecting tubules. Okay, so this is in short in regarding the renin, angiotensin, aldosterone system. So exam point of view, you can get questions like the sequence, that what the question I have asked, the sequence can be asked, then from where the renin is secreted. So what is the role of juxtaglomerular apparatus, what is the role of liver in the renin, angiotensin, aldosterone system, then from where angiotensinogen is produced, how angiotensinogen is converting to angiotensin 1, what is the role of ACE, then from where ACE is getting secreted, then angiotensin 2. So many important points are there. Okay, so this is in short regarding the renin, angiotensin, aldosterone system. Any further doubts regarding this question, regarding this renin, angiotensin system, you can ask in the comment section, and I am very free to clear your doubts. Okay, so that's all regarding our 13th question in our series, 14th question in our series. Now we will move on to the last question in this series. So the 15th question: what diagnostic test for hematological disorder measures the size of erythrocytes and the hemoglobin content? So here the question is regarding a diagnostic test. Okay, so this is a diagnostic test, and in the diagnostic test you are need to find out the size of the erythrocyte and the hemoglobin content. Then what test you will be advising for the patient? So options are: option number A, red blood cell count; option B, hemoglobin level; option C, hematocrit level; and option D, red blood cell indices. So which all things you will include, which diagnostic test you will advise for the patient to find out the size of the erythrocyte and the hemoglobin content? So by the process of elimination itself, you can find out the answer for this question, because it is not the RBC count, it is not the hemoglobin level, it is not the hematocrit level, and the answer is option number D, that is the red blood cell indices. Okay, red blood cell indices. So what all things are coming under this red blood cell indices, and what all are the normal values, I will be explaining now. So red blood cell indices include, the first one is the MCV. So we have seen in the complete blood count, you can see MCV, MCH, MCHC, what all these things. So I'll be explaining now. Average red blood cell size, okay, mean corpuscular volume, otherwise known as the mean corpuscular volume. So the first indices is the average red blood cell size. Then next comes the hemoglobin amount per red blood cell, that is the mean concentration of the hemoglobin. Okay, so that is the hemoglobin amount per red blood cell. And finally the amount of hemoglobin relative to the size of the cell, okay, per red blood cell. Okay, that is the MCHC. Okay, mean corpuscular hemoglobin concentration. Okay, mean corpuscular hemoglobin concentration, that is the amount of hemoglobin which is relative to the size of the cell per red blood cell. Okay, per red blood cell. So these are the three indices which are coming under the RBC indices, that is the MCV, MCH and MCHC, and we will see the normal values also. So MCV, the normal value is 80 to 100 femtoliter, then MCH is 27 to 31 picograms per cell, and MCHC is 32 to 36 gram per deciliter. or 320 to 360 grams per liter. Okay, so these are the normal values. So in exam point of view and for understanding purpose also, this is very important, because every time in the complete hemogram we can see the MCV, MCH, MCHC, these things. Okay, so I think you got some information regarding the indices. Okay, so this was one question which was asked before for the AIIMS NORCET examination. The other options also we will see. So what is the RBC count? RBC count, you know that red blood cell count measures the number of RBCs per cubic millimeter of blood. Okay, so in RBCs test we are not seeing the size of the RBC and its concentration and all. We are not seeing. We are just seeing the number of RBCs that present in per cubic millimeter of blood. Then the another option was the hemoglobin level. So hemoglobin level, it measures the hemoglobin content of the erythrocytes. That means the amount of hemoglobin in the RBC by measuring the number of grams of hemoglobin per 100 milliliter of blood. Okay, so this also you have to remember that we are measuring it per 100 milliliter of the blood, 100 ml of the blood. Okay, that is the hemoglobin level. And the final another option was the hematocrit. So hematocrit level is the measure of volume of RBC in whole blood expressed as a percentage. Okay, it is a measure of the volume of RBC that is present, in the whole blood. So there is a formula for calculating the hematocrit, that is the RBC divided by plasma. Hematocrit is the RBC divided by plasma, so that is expressed in percentage. Okay, so this is RBC count, hemoglobin level and hematocrit level. Okay, so from this final question you are getting information regarding the RBC indices that already we have explained. Then what is RBC count, what is hemoglobin level, and what is hematocrit level, and I am not explaining the normal values, that we can refer later. So with that question we are coming to the end of another important session. So I thank everyone who are watching this video till the end, and I request everyone who are watching this video to share about this platform to your nursing friends and supporters. And I hope these 15 questions what I have explained today are very important in exam point of view, and the explanations also. So thank you for being in touch with us. So kindly be in touch with us, so that we will be uploading the new videos very shortly. So till that time, signing out. Thank you.